Up next, we have a presentation by Dr. Anitha M, Professor and Head of the Department of Reproductive Medicine at Medical College, Trivandrum. She will be speaking on the topic obese infertile female. Let's warmly welcome Dr. Anitha Ma'am.
Good morning, and let me at the outset thank Dr. Jayakrishan sir and his team for letting me be here for this wonderful conference. Are there any PGs here, postgraduates? So the topic for today is obese infertile female, and I'll try to go through these headings: definition, the diagnosis, the pathogenesis, and obesity as a cause of infertility, the evidence present. I'll just brush through management, not in detail, and certain interesting facts. Now, what is obesity? Obesity is just excess of triglycerides in the adipose tissue. That is an excess of body fat. And there's a difference between obesity and overweight. Overweight is a sum total. It's an excess of body weight, including muscle, bone, fat, and body water, in excess of some standard or ideal weight we have determined or we have set. So many individuals at a weight which is very close to ideal body weight may be overweight, but not having excess fat. This is especially so for athletes and those engaged in regular exercise. So measurement of body fat is the more meaningful than a measurement of height and weight. Now, fat distribution. You all know that there are several topographic patterns. You have an upper body or central or android obesity, which is actually an intra-abdominal or visceral obesity, and they are sensitive to catecholamines but not much to insulin, so you have more chance of metabolic syndrome. That's what we are all worried about. Second is the lower body or the gynoid obesity, or the femoral or the gluteal obesity, which is resistant to catecholamines but more sensitive to insulin. So they are just less likely to develop metabolic syndrome, cardiovascular disease, and diabetes, but they are resistant to mobilization. It's very difficult to shed a gynoid fat. So fat deposition in abdominal or visceral region is important clinically, as it plays the most significant role in the pathogenesis of metabolic syndrome. Now, this is exactly what I said. You have the apple-shaped obesity and the pear-shaped obesity. We are more concerned about the apple-shaped obesity. And upper body obesity, as I already mentioned, is more closely associated with metabolic disturbances and reproductive abnormalities, including ovulatory dysfunction. And the best measure of upper body obesity is the waist-hip ratio. It should be less than 9.9 for men and less than 0.85 for females. We have the BMI classification. You know, there's a WHO classification, and we have an Asian classification where all the points are set at a lower level, because obesity for us will start at 25, whereas for a WHO it starts at 30. Why? Because in South Asians, body fat are more centralized, with mean waist-hip ratio being higher for a given level of BMI compared to Europeans. So morbidity and mortality were found to be occurring at lower BMI compared to Europeans, since BMI cutoffs have been redefined in the Asian population. Now, this is metabolic syndrome. You all know the different classifications: 2 out of 3 or 2 out of 5 of 3 out of 5 for most, and waist-hip ratio is taken in NCEP, waist-hip ratio in WHO. A bit about fat metabolism. That's why I asked whether PGs are there. When glucose is abundant, it is utilized in the fat cells to make glycerophosphate. And glycerophosphate is esterified with 3 molecules of free fatty acids to form triglyceride, which is a storage form of fat. Now, so glucose is a supplier of glycerophosphate. This is considered the late limiting step of lipogenesis. And when glucose is scarce, glycerophosphate production is reduced. Fat cells will release FFA and by a lipoprotein lipase action. And insulin is the only major physiological antagonist to lipase. So in the presence of insulin, free fatty acids are not much released, and the reverse occurs. In short, when a person eats, glucose is available, insulin is secreted, and fat is stored. When a patient fasts, glucose level falls, insulin falls, and fat will be mobilized. There is a physiological feedback loop which is centered at the hypothalamus. You have the arcuate nucleus, and these are the 2 neurons which you should keep in mind. POMC neurons, which is in the arcuate nucleus of the hypothalamus, pro-opiomelanocortin, which is a source of ACTH and mSH, and melanocortin released decreases appetite. And you have the neuropeptide Y and agotin related protein in the ventromedial part again of the arcuate nucleus, which will stimulate eating. So these are the 2 neurons. One stimulates, the other decreases eating. And the 2 hormones which are involved are the leptin and the ghrelin. Leptin is produced by the adipose tissue. It prevents obesity. Leptin means thin, so it reduces or prevents obesity. And ghrelin is secreted mainly from the upper part of the stomach, which will stimulate eating. So both leptin and ghrelin acts through the hormones which I mentioned, POMC, NYP, and agonist-related peptide. And ghrelin is the only hormone known to stimulate food intake. This is a physiological feedback. When you eat, the pancreas release insulin, the fat cells release leptin. They will stimulate the POMC neurons, melanocortin is increased, and satiety center is stimulated. At the same time, they will suppress the eating neurons. That is NYP. I'll call it the eating neurons for easiness. NYP and agonist-related peptides are reduced. In the opposite act happens when you fast. When you fast, what happens is the pancreas reduce insulin, there's no insulin secretion, leptin is also reduced. So ghrelin steps in from the stomach, it will suppress the POMC neurons and eating is stimulated. And it will reduce POMC neurons and then it will stimulate the NYP neurons which will stimulate eating. So these are the physiological feedback which should keep in mind. Now endocrinological changes in obesity, insulin level is always proportional to the fat. The more fat, the more insulin. And insulin, as I already mentioned in the two loops we have shown here, acts through leptin. And increased insulin, after some time what happens when there is excess of insulin, it will downregulate its own receptors and there develops the insulin resistance. Once insulin resistance steps in, all the metabolism, carbohydrate, fat and protein are affected. So fat is no longer stored, free fatty acids are released, and this leads to atherosclerosis and heart disease and all those things. And hyperinsulinemia, you should always keep in mind, is associated with obesity and is reversible with weight loss. Significant improvement in insulin resistance will be seen if you shed at least 5 to 10% of your body weight. This is already what has been mentioned. The only thing what you should understand is when there is obesity and there is insulin resistance, there is attenuation of leptin receptor signaling at the blood-brain barrier. So leptin cannot act on the satiety center. There you have excessive eating. So you are not able to shed weight. Now, how does obesity affect infertility or cause infertility? Obesity, you have insulin levels elevated, it lowers the serum hormone binding globulin. Once that is reduced, you have free floating or unbound fraction of free estrogen and testosterone, and this leads to a functional hyperestrogenism. Whenever there is a chronic low level of estrogen increased, it will affect the HPO axis, it will lead to an ovulatory dysfunction, therefore menstrual irregularity, increased risk of breast and endometrial carcinoma. And also insulin will lead to high androgens because it acts through the IGF receptors. IGF receptors are again stimulated in obesity, and that will act to IGF receptors which will stimulate the aromatase activity, increased estrogen secretion response to FSH, and LH receptors and increased androgen synthesis through LH. So what in sum total what you have is a hyperestrogenism with a hyperandrogenism which will be similar to your PCOS morphology. And there's something called a critical weight hypothesis which you are aware of. You need at least 17% of body fat for a young pubertal girl to achieve menarche. Now how does the brain recognize that this 17% of fat is there? It is through leptin. So fat talks to brain via leptin, and once leptin is defective, the whole thing will not function. You have amenorrhea and other things. So low levels of leptin serve as a signal that fat stores are insufficient for growth and reproduction, so gonadotropin secretion will reduce. Now are there any guidelines we have? We have this is age-old guideline, this starting in chronological order British Fertility Society by Adam Ballan, which said women should we should start infertility management only when the BMI is less than 35, preferably less than 30. Now this is the one guideline which is recent, 2021 ASRM practice guidelines. They say obesity in women is associated with ovulatory dysfunction, reduced ovarian responsiveness to agents that induce ovulation, altered oocyte as well as endometrial function, and lower the birth rates. And in anovulated women with obesity, weight loss interventions improve the chance of unassisted conception, improve the chance of ovulation in response to ovulation induction, but they have not shown to increase the live birth rate. And the effect of pre-pregnancy weight loss interventions on maternal and fetal complications are unclear. So the effect of lifestyle interventions on live birth rate, they are not clear about it. And but obesity should not be the sole criteria for you to deny access to fertility treatment. lifestyle modification and medical therapy have demonstrated effectiveness in promoting weight loss. But the effect on infertility, they were not very clear. Bariatric surgery, again they said, is a good adjuvant to both medication as well as lifestyle therapy. But once you give a bariatric therapy, you know that the nutritional status of the woman will be stabilized only after a year or so. So you have to wait for 1 year before you start infertility management. And they also concluded that there is no medical or ethical directive for adopting a statewide BMI threshold for offering infertility management. So there is no threshold to say that beyond this you can start treatment and less than that you cannot. Now this is something which everyone knows, the PSO guideline 2023 combined statement by Monash, ESHRE, ASRM and the Endocrine Society. They also promote lifestyle management. It's a grade 4 recommendation saying that lifestyle intervention should be recommended for all women with PCOS who are obese, and the focus should be on the entire life of the patient with improvement of central adiposity. Now coming to the evidences, few evidences we have here. The Cochrane didn't find much evidence. Cochrane evidence, they said, was insufficient to permit a conclusion on the effect and safety of preconception lifestyle on the various aspects of infertility. Now this was a recent RCT 2024, this is a Chinese group where they said weight loss before IVF did not increase the live birth rate in women. They didn't find a significance. And this again is a 2023, it's a cross-sectional study. This is actually done by a Chinese group, but the data was taken from the National Center for Health Statistics USA. The USA data they have taken, and they found that there was a 2% rise in incidence of infertility for every centimeter rise in waist circumference. So waist circumference has to be brought, that your central adiposity should be brought down. Now this is again a lifestyle intervention study. This was an Eastern European Slovenia Latvia group. They did a systemic review and meta-analysis, and they showed that lifestyle interventions on reducing beneficial effect on reducing weight, waist circumference and BMI on increasing the fertility aspect. So beneficial effect on lifestyle intervention on ovulation incidence and sex hormone binding globulin was seen. Lifestyle intervention group had 11.23 times more ovulatory incidence than the control group, which in turn increases the ability to conceive. So they said it should be incorporated in your infertility management. Now this is again recent 2024 meta-analysis of impact of body mass index on obese women polycystic ovaries, and they found that in PCOS undergoing ART who are overweight or obese, the live birth rate, clinical pregnancy rate, implantation rate, retrieved oocytes were less than in normal-weight patients. So patients with PCOS who are overweight had a negative effect on ART and ART pregnancy outcomes. So this is I took just one statistical part of it. The live birth rate were found to be reduced both in the overweight as well as in the obese. Now this is again a metabolic syndrome in obesity. This is a cohort analysis. This was just a subgroup analysis of an old pregnancy in PCOS trial, Legro in 2007. They did a subgroup analysis and they found that fewer women achieve clinical pregnancy and a live birth rate in the presence of metabolic syndrome. That is, it was clinically statistically significant. So conclusion, they said metabolic syndrome is a risk factor that lowers the live birth rate with ovulation induction for women with PCOS independent of obesity. And then this is a lifestyle study. This came in 2016 where they grouped patients into two groups. One is patient with lifestyle intervention for 6 months followed by infertility treatment. The second is infertility treatment alone. And they found that live birth rate did not vary between the two groups. And then this was a fallout of that. They did a subgroup analysis into 4 subgroups depending on the age, ovulatory status, BMI and waist to ratio. Again, they didn't find any improvement in live birth rate with lifestyle intervention, but they found that there was increased natural conception in obese and ovulatory patients, not in the ovulatory patients. So they advise us for obese non-ovulatory patients, lifestyle modifications will lead to more natural conceptions, and this is a chart. Natural conceptions are increased in those with had interventions. And this is another review, randomized control trial, a review of RCTs. Again, that's weight loss interventions, and they found that pregnancy rates were higher in women undergoing preconception weight loss, but that again no impact on live birth rate. And this is the Fit for Fertility study. This is an ongoing trial in Canada, 7 centers across Canada. They have just recruited, same as the lifestyle study, 2 groups with lifestyle intervention plus infertility treatment in one arm and infertility treatment straight in the other arm. They have just started recruiting. Maybe it take 2 more years for the report to come. It's again RCT. So that is a protocol. And management, I'll just brush through. You know the lifestyle management, exercise, diet, restriction of calories, drugs, they have said to be effective, and bariatric surgeries. Lifestyle, you have the international guidelines in PCOS, which states you have to walk for 150 to 300 minutes of exercise for moderate, and for 170 to 150 of minutes of intense exercise. Anti-obesity medications can be given. And bariatric, they specifically said PCOS is a condition where it should be considered as a low threshold for bariatric surgery. It has to be, it can be done, and when it is done, you wait for 1 year for the nutritional status of the woman to stabilize. Now, these are few interesting facts which I came across. This is not for patient, but this for all of us. For most of us have crossed the 40s, 50s, and the 60s. You are struggling to shed weight or not to gain weight. So these are certain interesting facts I came across. Maybe it will help in counseling your patients. The basic metabolic rate, as you know, decreases with age. After 18, the resting metabolic rate declines 2% per decade. So a 30-year-old man who will inevitably gain, man or woman, will inevitably gain weight if there is no change in calorie or exercise level over there. Even if he does the same thing, he is going to gain weight. And obesity is hypothesized as resistance to leptin. So leptin is the key role. A lot of research is going on in the area of leptin, where they're trying to find an analog, because leptin, once the resistance to the attenuation comes in obesity, it will not cross the blood-brain barrier to stimulate the satiety center. Now the next sentence, it will be confusing. I'll just explain it. You have a leptin adipose tissue in one level in a patient, whether it's lean or obese, and there's a set leptin for that obesity level. For a thin patient, suppose it is 5, he stops eating, fasting, he drops by 3 units, it reaches 2, the body senses the body is in danger, ghrelin steps in, and the man starts eating again. But for an obese, his body weight is very high, the fat is high, he has a leptin of 8. He also drops 3 points when fasting, reaches 5. But then, by then, the ghrelin steps in, thinking it is dangerous to fast more. So he starts eating at a higher leptin level than a person who is thinner. So that is why obese people find it very difficult to lose weight. We often blame the patients. They come and sit in front of you and tell you, "Oh, I'm eating and not eating anything, madam, but I'm not losing weight." You think she's lying. She's not. It's ghrelin is the culprit, because ghrelin steps in earlier for obese people than for a thin patient. So whenever perturbation occurs, leptin and ghrelin levels change to restore the original status quo, making it difficult for overweight people to maintain or to lose weight. And weight loss can be maintained only by a strict diet or increase in physical activity to overcome body's attempt to restore the original set point. And best diet is limitation of calories by 100 to 1200 calories, you know the proportion approximately. And the good point is, approximately 9 to 50% of the patients who lose weight subsequently will gain it. And a weight loss, remember, of 5 to 10% produces beneficial effects on both cardiovascular disease and diabetes. For certain inherited abscess, the question is whether you are born with so much of fat cells or you gain later. So there's a controversy there. Mean fat cell volume increases 3-fold in the obese, but increase in the number, that is a hyperplasia of the cells, occurs only in grossly obese. A person is born with set number of cells, which is acquired either during the intrauterine life, infancy, adolescence. Now in intrauterine life, the problem is when the maternal obesity is there, gestational diabetes, macrosomia, the baby acquires large number of cells. That is a hyperplasia of the cells, and the child will have childhood obesity and adult obesity, very difficult to manage. But when a person acquires weight later in the life, it is mainly because of hyperplasia, which is amenable to reduction by weight. 2 more minutes. Amenable to reduction by your dieting. And so for conclude, the higher BMI is associated with the reduced pregnancy rate even in women with ovulatory cycles, equating to 4% decrease in pregnancy rate per kilogram body weight of BMI. Women with obesity are also likely to develop, you have hyperandrogenism and irregular cycles, so PCOS-like syndrome. And Studies assessing the ART, that is ART procedures, have reported that women with obesity require larger doses and longer duration of oral ovulogins as well as gonadotrophins, display a lower pregnancy rate, and at high risk of cycle cancellation and miscarriage. Obesity increases the risk of pregnancy complications like gestational diabetes, preeclampsia, cesarean section, etc., etc. And in keeping with the developmental origin of health disease paradigm, maternal pre-pregnancy BMI and excessive gestational weight during pregnancy are consistently associated with the early development of obesity and diabetes in the offspring. The child will become an adult obese in adult, will have obesity in adulthood also. So obesity in childhood is closely linked to adult obesity, perpetuating the intergenerational cycle of obesity. So mother obese, he is obese, his child will also be obese. So adopting a healthy lifestyle before conception and restoring a healthy metabolic environment during pregnancy represents the best approach to break this vicious cycle of intergenerational propagation of obesity and diabetes. Accordingly, targeting women with obesity prior to conception may be essential to reduce the burden of infertility, ART cause, as well as obesity and cardiometabolic diseases in the society. It reflects in the society also. Thank you.
Thank you so much, ma'am.